So coming to the next topic is regarding aortic dissections and aortic aneurysms. So how's the vessel wall? A vessel has got a wall which has got three layers. Outermost, innermost is intima and media as well as adventitia. So if you see, this is innermost, and in between two there is elastic layer, that is media. You can see pink is media and blue is intima. So if all three walls get dilated, that is a true aneurysm. And if only outer wall is dilated and there is penetration, if tear in the intima and medial loss, then that is false aneurysm. And dissection is sometimes it occurs, the blood goes inside the layers of this, so that is dissection. So intimal layer is followed by formation of, so what happens, there is a tear in the intimal layer. You got, this is the outermost layer, then there is elastic layer in between, this has got elasticity, and the innermost is intima. So the innermost layer is torn, intima, then formation of progression of blood into subintimal. The blood goes from this inside lumen into subintimal space, and that lifts the other layers up, and this is called as dissection. We are doing dissection inside, so that dissection is called as aortic dissection. One of the most common aortic pathologies, 33% patients die within first 24 hours. Whenever there is dissection, there is total disturbance in the physiology, and it goes, person goes, 33% patient dies in one day, within a day. 50% die. If 48 hours they survive, 50% persons die. What is the predisposing factor? If the blood pressure increases, hypertension, lot of pressure inside, that causes pressure on the walls. And in congenital cases like Marfan syndrome, pathology, cystic medial necrosis. So there is necrosis in the medial wall. Medial wall contains the elasticity. Basically, it gives the elasticity. If there is necrosis, then intima is torn there. Most common site of dissection is 90% occurring. 90% of the dissections occur 10 centimeter from the aortic wall. So this, if you see, aorta is rising like this. It is arch of aorta, and these are the aortic walls from the left ventricle, and above is left atrium. So this first 10 centimeter, so it occurs within 10 centimeter of aortic wall. Basically, the ventricle is pumping, this ventricle is pumping lot of blood inside, and there, so within 10 centimeter the dissection starts from here. Once it starts, instead of going like this, some of the blood goes into in between the walls, and that causes aneurysms. This causes dissection, and indirectly you can call it as a, so classification now, Stanford and DBK's classification. Stanford, they have described into type A and B. So ascending aorta and aortic root. Now you can see in this, Stanford has just A and B, two types. If anywhere dissection starts from the dissection aorta or aortic root, you can see this is aorta, this is arch of aorta, and this is descending aorta. So from aorta, this is the root. If it is beyond this arch, type B is from this start of the descending. So ascending an arch, that is type A, descending is type B as per Stanford. If you see DBK's, it has again divided into three types. Ascending aorta, arch, and descending all is 1. This one is 1. If ascending aorta only, limited to this, is ascending aorta only, and descending aorta distal to left subclavian. Here subclavian is taken as a border. So descending arch in this. So type 1 and 2, that is supposed to be in a type 1 and 2 is supposed to be type A of Stanford. So what you have to see, Stanford is start point. Stanford start point. If it is starting from ascending, A. If it is starting from descending, take it as B. And D, Becky. Becky has got 3 types: 1, 2, and 3. One is site affected. This depends upon the site. If it is ascending arch, descending all, type A is all is worst. If it is only ascending is 2. If it is descending it is 3. So take, so D Becky, it is from the site. Now what are clinical features? If you see clinical features, what happens? There is sudden tearing chest pain. Person is severe chest pain. 10% is painless. Hypertension has to be there. Myocardial infarction if coronary ostia. Blood pressure differences in each arm. You have to measure is greater than 20 mmHg. There is difference in blood pressure in the 2 arms. Then neurological deficit, abdominal pain. Investigation, widening. There is you can see this widening mediastinum is widened, and abnormal aortic knob, deviation of the trachea and esophagus. CT angiography if it is more than MR angiography. The treatment mentioned in the table above. Here the treatment is given. If it is type A, means start point is limited to is starting from the surgery aortic root replacement. If it is type B, descending aorta, in this you can go for beta blocker, heart rate 60, 80 and systolic BP. We have to give beta blockers. Mention time. Type B treatment, if the patient develops any signs of malperfusion, hemodynamic constable, he will indicate for surgical. So this was about the dissection. Now you are coming to aortic aneurysms. Just now I have seen here there is all 3 layers. First, all 3 layers. This is saccular. This is again all 3 layers, fusiform. This is dissecting. Blood is passing in between the layers, and this falls only outer layer is involved. It's enlargement of artery by one end of the other. So 1.5 of the normal size. 1.5 normal size. If it is 1.5 is the normal, it has to become 1.5 times into 1.5. So it will be around 2.25 centimeter. So if it is 2 centimeter, then 1.5 times it has to 3 centimeter, 1.5 times. So that is called as aneurysm. But ruptured aneurysm can lead to fatal complications. Types true and false. You are seeing classified according to shape, that is saccular, fusiform, dissecting, false. False aneurysm or pseudoaneurysm is when the blood is entering into the wall, injured and leaking. The blood collects surrounding tissue surrounded by the false fibrous capsule. Pseudoaneurysm may be complication of the cardiac catheterization. When you try to do cardiac catheterization, if suppose catheter is going inside, that is peripheral angioplasty, any of the pseudoaneurysms are formed. Management is ultrasound guided compression. If there is pseudo, you have to go do early management little bit. If you get little bit, so guided compression repair. Thrombin injection if the neck is less than 2.5, it's not big, just 2.5 centimeter, it is very small hole. You have to put a thrombin injection to patch that. EVAR, endovascular stenting and open surgical repair. True aneurysm, atherosclerosis is considered the most common cause. High blood pressure, smoking, commonest risk factors. Infections, usually mycotic aneurysms, is the most common type associated with the infective endocarditis. Staph aureus, again here Staph aureus is the most common organism. These are acquired. Smoking, blood pressure, smoking, high blood pressure, and infections, mycotic aneurysms of the heart walls. So these are the acquired. In congenital you get Marfan syndrome. This question is most commonly asked. Marfan syndrome, there is tissue abnormality. In this again the same thing, the intima has got elasticity, which has got loss in elasticity in intima, so it cannot be this vessel, large vessel. This, when there is pressure and pump, due to elasticity it will increase and decrease, but if elasticity is lost, this wave cannot be maintained, so the wall becomes suddenly dilated. Congenital syndrome that affects the body connective tissue defects in fibrillin. This question is also asked. Fibrillin is related to Marfan syndrome. Fibrillin. Tall people, tall limbs. What you see, there is flexible joints and hernia. People with this syndrome usually have aneurysms. Mostly asymptomatic. Impending rupture is the rupture. Management usually CTA is the best. Coronary is CT angiography. CT angiography. You have to do CT angio to measure best investigation modality. Treatment is urgent is only indicated if patients are symptomatic. If patients having symptoms in aneurysm, effective intervention indicated the aneurysm, which is a size. So size is more important in this. If aorta, this is asked all the time, aortic aneurysm, if it is more than 5.5 centimeter, this is the demarcation, this is the size limit of the size. Beyond this you have to go for, if it is up to iliac arteries 3.5 centimeter, popliteal 2 centimeter, and femoral 2.5. So Berry's aneurysm, secular type, congenital, subarachnoid. This certainly in the brain. You get Marfan type, fusiform, congenital due to medial cystic necrosis. Cystic necrosis, it can occur anywhere. Abdominal aortic aneurysm. Most of the questions are asked in this. Common problem in vascular surgery may occur as true and false aneurysm. True abdominal aortic aneurysm have approximately incidence of 0.6 per 1000. Means if you increase to 10 here, it will be 0.06, 0.6, 206. It will be 6 per lakh population. 6 persons is having. These are commonest in elderly men. For this reason, UK is now introducing. They do screening program. So 6 in 1 lakh population. So this number is very high. So they are doing screening program for abdominal aortic aneurysm, measuring men above 65 years. Clinical picture same plus severe abdominal pain related to back. Management, most abdominal aneurysms are incidental. When you do normal ultrasonography, there is incidental finding. Symptoms most often relate to rupture, impending rupture. So abdominal aortic aneurysm, if it is 3 to 3.9 centimeter, the risk is not there. So up to 3 centimeter to 3.9, see this diameter, 3 to 3.9, this is normal. If it increases to 4 to 4.9, diameter increases 4 to 4.9, 1% risk. Again now 5 to 5.9, 6 and above. When it goes to 6 and above, and 7 centimeter, see this 7 centimeter, 5.5 centimeter is taken as a risk. 5.5 centimeter. If you see 1 centimeter is this much, so this much. If it increases to this much size, roughly this size, 1, 2, 3, 4, 5. If so, 5.5 when it increases size. Now rupture, patients frail plus multiple morbidity, palliative care, and die in peace. Patient fit, urgent surgery. If patient is unfit, let him die in peace. Because once the abdomen ruptures, it is not possible. If not rupture more than 5.5, proceed with surgery within 2 days. You can't wait for long time. If it less than 5, follow up sonography every 6 months. Every 6 months you have to see sonography and measure it. Fluid using resuscitation, 1 liter Hartmann solution. over 4 hours to prevent rupture of hematoma. Management may be open or EVAR and two types. Symptomatic aneurysm 80% annually mortality, increase in size above 5.5 if asymptomatic. Complications of aortic surgery, what you do, what you get, there is embolus in the lower limb, embolism, trash foot, embolus in the lower limb gets to trash foot, embolic gut ischemia anywhere. Now you are doing this aneurysm of the abdominal aorta, celiac axis, superior SMA, celiac, IMA, then it is dividing into common iliac, external iliac, internal iliac. So external iliac going to leg. So if you do repair anywhere, the embolus may go anywhere in the periphery, and that causes blockage of the vessels, distal vessels. If it is causing to the lower limb, it will lead to trash foot. It causes gut ischemia, paraplegia due to spinal vessels, because cardiac going to premorbid stellary perfusion. Reperfusion can lead to heart failure. Risk related to graft infection. Whatever graft you have put, it may cause infection. Now aneurysm at the knee joint posteriorly. You can see in the popliteal fossa, you see artery is the deepest part, and tibial nerve is the most superficial. The most common peripheral aneurysm, 25% of the patients with abdominal aortic aneurysm. If you have got abdominal aortic aneurysm, popliteal aneurysm has to be there. Very rare to rupture. Indication for surgery, acute limb ischemia. If it is causing this aneurysm, causing severe ischemia, severe claudication, asymptomatic. Thrombosis inside the aneurysm, size if more than 2 cm. Commonest vascular aneurysm is aortic, and then commonest peripheral, popliteal is commonest, then femoral. So that was about the aneurysm.